I request Dr. Priya Chandrasekhar to chair this session and Dr. Priya Chandrasekhar is a pediatrician by profession with a special interest in handling children with Down syndrome, and she's done quite a bit of research and published papers. One of her areas of special interest is nutrition in children. And she's been part of the WDSC and also APDSF. And very happy to invite Priya to chair this session, please.
It's not working. Good afternoon, all of you. Now that you all had food for the palate, let's have some food for thought. I would like to call Karan to introduce Dr. Bhavani Sriram, our keynote speaker for this session. Karan is a self-advocate.
Hello everyone. I welcome on behalf of SIFI Dr. Bhavani Sriram, neonatologist, specialist in managing Down syndrome neonatals. She has completed her MBBS from Stanley Medical College, Chennai. She is a medical advisor for DSA Singapore and member of Royal College of Physicians, England, to come and deliver her speech. Please, thank you.
Thank you, Karan. That was very nice. Dr. Bhavani has done a lot of work and has a special clinic for the past 20 years in Singapore. Welcome, Dr. Bhavani.
Hi, a very good afternoon to all of you. Thank you, Karan, for that very kind introduction, and thank you, Priya, as well. Very good afternoon to all of you, parents, persons with Down syndrome, and distinguished guests. I'm extremely honored to be here in the capital city of India to attend and to be a speaker in the first Indian International Down Syndrome Congress. I thank the organizers for the same. So I think, like what we were mentioning, you had a lovely lunch, and this is what we call as postprandial stupor, where you feel very sleepy. And this, I thought maybe this is one of the ways I could wake you up, but maybe my talk will do better. So let's just move on to some aspects that I'm going to discuss. I come from Singapore, and what I'm going to try and discuss today is on just the health checklist for persons with Down syndrome. I'm going to address some controversies and concerns. I'm going to try and educate on these controversies and concerns because I think as parents, when you actually make choice decisions on treatment or requesting for investigations from your own primary physicians, you need to know why you're asking for these. So you all carry health checklists with you, you carry books, you read websites, but it's good for you to have a little bit of understanding what these checklists actually mean, so that at least you can have a sound knowledge on making choice decisions on treatment. So we'll just run through a few of these issues on life expectancy, on some health screening checklists and guidelines, and I'll discuss on 4 important areas which are quite close to my heart. And they are about the thyroid dysfunction in persons with Down syndrome, and this actually remains a point of concern from childhood all the way to adulthood and aging. Cervical spine abnormalities and monitoring, what do we need to do? What are the concerns? Growth monitoring in persons with Down syndrome, and some aspects of sleep-related disorders. So these are my 4 areas of interest, and this is what I'm going to talk about. So what are the causes of improved survival? I just need you to understand what was the life expectancy of persons with Down syndrome when you talk about 1929 and 1949. So they lived about 9 years, 12 years, gradually graduated over decades, 18, 30, 35. And now, if you look at the life expectancy or the mean life expectancy in most developed countries, we range anywhere between 50 and 60 years. Now, this couldn't have happened overnight, yeah? It's happened over decades. And why do you think this could have happened? And I think the presence of the checklist or the supervision guidelines have played a very, very important role. One of the most important being detection of cardiac anomalies and treatment that is instituted as early as possible. So if you just look at the red column, 1994, the American Academy of Pediatrics recommended cardiac screening. Between 1993 and 1997, we had cardiac surgery, which has emerged. And by 2014, we have extremely good results, which paved the way for congenital heart disease detection as well as treatment. The health guidelines and checklists, I won't go through. It's a busy slide, but I think you all understand there are plenty, and I think India has their own checklists and guidelines, and it's very important as families that you need to get yourself educated with the checklist, as well as to empower persons with Down syndrome to go through the checklist and understand, because just as you do self-advocacy for various inclusiveness and activities, you need to have self-advocacy for health as well. So we're going to talk a little bit on thyroid disorders, just for you to understand as to why this thyroid has become such a major issue. We talk about some of the types of thyroid disorders, what are the current recommendations, when do you treat, what are the controversies, how long do you treat. So thyroid gland, as you all know, is an endocrine gland that is situated in the region of the neck. It basically produces two important hormones, which is what is usually measured in the blood. So when you go for a thyroid test, two hormones are usually the one that is measured is called the free T4. And it is a complex system because it is controlled by the brain. Some of the important hormones from the brain actually stimulate your thyroid gland, and the glands in the brain acts like a thermostat. So when something is low, it stimulates to make it high. When something is high, it stimulates to make it go low. So two important hormones that are usually measured in the blood is the thyroid stimulating hormone, otherwise called TSH, and the other one is called the free T4. Sometimes, in some centers, they would measure free T3 too, but the two important hormones are TSH and free T4. What does the thyroid gland do? It's got multiple functions, and that's why we keep insisting on doing the thyroid blood test so frequently. It does control various systems. It controls the breathing, it controls the heart rate, it does control the central and peripheral nervous system or the nervous system, controls the body weight, growth, cholesterol, so it's got multiple functions. So when we read the thyroid function test, I very often, when I explain to the families, they are very confused because when we say down, we mean that it is up. It's a complex situation, but it's very important that you understand. The commonest entity is, if you can look at the second column, in persons with Down syndrome is usually called mild hypothyroidism, compensated hypothyroidism, subclinical hypothyroidism. These are the terms that are commonly used by medical professionals. We do have another extremes of range called the congenital hypothyroidism and hyper, which is higher functioning of the gland. These are the various conditions that you can come across during the lifespan of a person with Down syndrome, where you call it congenital, which means it's present at birth, and the significance is that you need lifelong treatment. Subclinical or mild hypothyroidism is the controversial area, and I'll just go through a little bit about it. Autoimmune is when you have your own antibodies produced in the body that kind of attacks the important organs, and that's something that we encounter in persons with Down syndrome. So what is congenital hypothyroidism? Is basically you have a poorly functioning thyroid gland which is detected at birth, and if you just look at the red numbers, the incidence in newborns or children with Down syndrome is about 1 in 140 when compared to a neurotypical population where the incidence is 1 in 2,000. So we are nearly 20 times higher. So it calls for importance for screening in the newborn period that you have a thyroid test done at birth so that you pick up this congenital hypothyroidism, and it's really important that you start treatment immediately. And I'll tell you why. Subclinical hypothyroidism is the complicated one where basically you have a higher thyroid stimulating hormone, which is the hormone that is produced by the brain, but you have a normal free T4. Normal free T4 means it looks like your thyroid is functioning normally. So why then are you worried if you have a normal hormone that's actually important for the function of all the important things I mentioned about? Why then do you need to keep following, and why then do you need to treat it at all if you have a normal free T4? And the reason is because there's a wide range of what we call as high TSH, anywhere ranging from 5 to 10. And the prevalence of this particular condition, which is, as I mentioned again, is the commonest in children as well as in persons with Down syndrome, is anywhere between 7 and 40%. So which means nearly half, you expect to see some changes in the thyroid gland, which will need close monitoring. And the important thing is there's no symptoms, which means, as you all know, if you have like a tummy ache, you know it's a symptom, you've got a problem here. Whereas with thyroid numbers, these are just numbers, and you don't very often present with symptoms for you to take your child to the doctor, and that's very important for you to note. So they present themselves in various forms, and they can be transient, and transient obviously means it happens, but it gets better spontaneously without treatment. Progression is they can get worse, and they can actually go into frank hypothyroidism, which is under-functioning of the gland, or it can be persistent. Now, why is it important? If you remember, lots of families actually ask me, so if I don't start treatment, can I just look and watch for symptoms, and maybe when the symptoms happen, I'll bring my child to you and then you can start treatment? The reason it's difficult is because there's so much of overlapping of features between a person with Down syndrome or a child with Down syndrome and hypothyroidism. So you can see that there are features with the tongue. They also have a poorly developed nasal bridge. They have poor muscle tone. They have delay in developmental milestones. So both of them overlap a lot. So how then would you say that this child has got hypothyroidism when most of the features are already present? So the clinical sequelae, and this is what I want you to focus on. If you can recall that even if you have a normal free T4, what will actually happen to you? Will you just be without any complications? Will you develop complications? Do you need to treat it early? Or can you just ignore the numbers and say, my child looks fine, why do I need treatment? The reason is people have actually studied this in detail, and they do note that there is a decrease in linear growth or weight gain or in head growth or in the development if the treatment is not instituted appropriately. So there are various studies, and these are the areas of controversies. So there have been some studies which look at treatment and say, if you treat a person with subclinical or mild or compensated hypothyroidism, what is the outcome? The outcomes are they did find that there was a small delay in motor development, which is what we're concerned about. So they actually have a better developmental scale, and there are greater gains in length as well as in weight. So if that definitely calls for treatment then, because you are seeing an improvement not only in development, but also in growth. But there's a controversial study which says, no, you don't really need to treat the subclinical hypothyroidism because it is a transient phenomena. People get better by themselves. Why do you want to subject a child to a treatment when 70% of them get better? So this is the area of controversy. Do you treat or you don't treat, and what number is considered as a good treatment value? So currently, we have, I'll just move on to the next slide. As far as we know, for parents, the take-home message is very clear. Whatever controversies we have at this stage, thyroid screening is mandatory. You do need to have a thyroid test done in the newborn period at 1 to 2 months of age, 1 year, and annually thereafter. The two hormones that you're looking at is what we call as TSH and free T4. Treatment is definitely needed if you have congenital hypothyroidism, which means hypothyroidism detected at birth, and that requires lifelong treatment. Subclinical hypothyroidism, an area of controversies. Most of us would definitely consider treatment if the number is more than 10, and we would definitely continue treatment for the first 4 to 5 years, where you want to catch up your growth potential and your development as well. Discontinuation of treatment should not be done at any point in time without consulting your physician. You should have protocols which are institution-based or within your own, if it is your own primary physician, they should have their own protocols and they should guide you in the treatment. I'm going to move on to the next one, which is called as craniovertebral, or this is otherwise called a cervical spine. and I think the previous speaker alluded upon this particular issue. The cervical spine basically consists of the cervical spine itself, and then it hosts the spinal canal and basically the spinal cord. The spinal cord contains all the nerves that is necessary for your movement, for your breathing. So it's a very, very vital, important organ. Now, what is the concern for persons with Down syndrome with regards to the cervical spine? This is just for you to understand an anatomy. The top one, what we call as the occiput, is the base of the skull, and the first two are basically called the cervical spine. So it's cervical spine 1, cervical spine 2. The first one is called the occipital cervical joint, and the bottom one is called the atlantoaxial joint or AA joint. Now, these joints are all held together by ligaments and muscles, and in view of the ligamentous laxity, there is a possibility that there is a shift of these structures which can cause compression of your spinal cord, which can lead to long-term sequelae. So these are the x-rays that are standard x-rays that are suggested in order to detect it. So you basically need to do an x-ray in flexion, extension, and neutral position, and their lateral x-rays to look for these two ligamentous changes that cause these shift in these, both in the upper and in the lower part of the cervical spine. The incidence of the cervical spine instability can be as high as 10 to 15%, and they are both due to ligaments as well as the bone structures that can sometimes be abnormal. Delayed recognition can sometimes lead to cord compression, which basically means it compresses your spinal cord and leads to concerns. And vast majority of them are asymptomatic, so you don't pick them up. But what is the important issue for families to know is that it is a concern, and if you do notice any of these things, you do notice that the walking is changed, you do notice that there is a change in the pattern of walking, you do notice that suddenly there's a tilt to one side or your child is complaining of pain in the neck, if there's clumsiness or incoordination which you haven't noticed in the past, then you definitely need to pay attention to the presence of the cervical cord abnormalities. But do you need to wait for this? Do you need to wait for these things to happen because you've already caused some damage to the cervical spine? Or do you need to pick it up early and institute treatment? Remember, when you actually do any screening process, the screening principally, the incidence should be fairly high, and you should have a treatment available for it. Because if you don't have a treatment, there's no point screening it. So this is an important thing for you to take home. So the first one I talked to you was about the occipital cervical, which is base of the skull and the first cervical spine. Incidence, as you can see, can be as high as 60%, which means it's more than half of them can have these changes in the cervical spine. And again, it can be ligament or it can be bone. They can be asymptomatic, or they can present with all those symptoms I mentioned to you about change in gait, limping, not walking well, clumsiness, and subluxation of more than 7 to 10 millimeters. So if they actually do standard x-rays that I mentioned to you earlier, the lateral x-rays in flexion, extension, neutral position, and they notice a number which is like that, 7 to 10 millimeters, the current indication is surgical intervention. Atlantoaxial, which is the one below, that is cervical 1 spine, cervical 2 spine, also happens in the same way, ligamentous laxities or bony or abnormalities, present in nearly 15 to 20%, and they can be asymptomatic, and a very small number present with symptoms. So then again, when you have no symptoms and you have a concern, do you screen? If you screen, what do you do? Because you don't have symptoms, but you actually find there are some changes. Do you need to keep monitoring them every 3 months? Do you need to tell your child, don't do this, don't do that? What exactly what can we offer? So obviously there was a concern, and Special Olympics actually said anybody who's participating in activities that have contact sports, jumping, trampolining, they say you must get an x-ray first. But then 10 years later, they looked at the incidence of these cord changes, and they said, really, we haven't had any problems. We don't need an x-ray. But obviously, when you have caused a lot of concern, physicians don't want to give it up because they've said, yes, you have concerns. Would you then allow your child to take part in Special Olympics and have a cord compression happen later? So physicians generally still continue to offer. And why are we concerned? If I do the x-ray and I do find some changes and you have a completely happy child who is running around, we will have to tell you to restrict some sports activities. We also know that these x-rays are extremely difficult to do because can you imagine a 3 to 5-year-old child sitting and down doing a neutral flexion extension x-ray which is perfect? What is the screening? Is the x-ray the best tool? Are radiographers actually specialized to read these x-rays properly to give you the exact numbers? So obviously we have a lot of concerns on this. But we still suggest at this point in time, because we don't have very good evidence, we don't have progression, we don't know whether this cord compression only occurs because of sports, or is it because of changes in the bone that happen to all of us over time, we cause cord compression. What is causing this? And since there's no progression, we still want to actually do the test. And these are some guidelines. It's just the numbers which are very important for radiographers and for physicians to know about, that when you see these numbers, you say, okay, this is an alarm signal, I need to take some action now. I'm just going to move on to growth. And basically, as we all know, growth is a very healthy indicator. It does reflect your health. It does reflect nutritional status. We all know we use standard growth charts, and growth charts are different in different countries. The growth potential we know is influenced by many factors. It's basically nutrition, genetic factors, health-related issues. And so it's very, very important you have growth-specific charts which are standardized to each country. Why? Because we do know that children with Down syndrome are generally shorter and they have a smaller head circumference which is measured at the age of 5 years. We do know the mean height that happens at 18 years actually is less than 2 standard deviations when compared to a neurotypical child. We do know that the pubertal growth spurt that we notice is not very often present, or it's much smaller scale in persons with Down syndrome. We do know that the BMI, or the body mass index, which is a reflector of obesity, is much higher, nearly about 25% in children who are about 18 years and above. So when you know these issues, you cannot afford to actually ignore it. And the causes of the growth delay has been postulated due to very many causes, but it's certainly important that you rule out medical causes because they are potentially treatable. So don't forget the presence of congenital heart disease, thyroid disorders, celiac disease, and milk allergies that the previous speaker was talking about, diabetes in older people, and nutritional causes. So it is important
1 minute left.
Sure. To monitor growth charts, which are country-specific. Look for medical causes if there is poor weight gain. Monitor weight for length and do the BMI, and appropriate interventions to be instituted. And this is just to, I'm not sure if you can see it, but basically your Indian Academy of Pediatrics growth chart that is used for typical children versus the dots that are usually for the persons with Down syndrome. You can see the mean height, or basically the 97th centile at 18 years. You're nearly about 10 centimeters away from a neurotypical child, or sometimes 16 to 20 centimeters in some charts. So it's very important you follow your own country's Down syndrome growth-specific charts. The last one I'm just going to talk to you about is about sleep apnea. Basically, just going to tell you, what do you mean when a child has had a good sleep, who functions well and is active in the morning and alert during the day? It is classified into 2 ranges: primary snoring, where you just snore, but you also have features of obstructive sleep apnea, where basically you don't have enough oxygen into your system. You collapse your airways and you have lesser oxygen. Nearly 50% of children with Down syndrome have obstructive sleep apnea, and they are due to multiple causes: tone changes, the tonsils and adenoids being enlarged, and obesity. Symptoms for parents to notice are mouth breathing, morning headaches, restless sleep. They are gasping during sleep and they get up suddenly. They have growth failure, they have learning difficulties, they have behaviors of concern which you haven't, what we call as challenging behaviors that you haven't noticed in the past, and some effects on the heart which are long-standing. So how do we actually go about? We get a focused sleep history. We do a clinical examination to look for tonsils and adenoids. There are standardized sleep questionnaires that can be used, and parents can use it to fill. And if you fall into the risk group, you basically have to do a sleep study. And there are the presence of urinary biomarkers, which I think one of the speakers will be talking to you later. But you need both clinical and you need sleep studies, and you classify them as mild, moderate, and severe. But these are all indices to tell you how low your oxygen drops during the sleep. And this is obviously detrimental to brain and all the important structures. Sleep's current recommendation, sleep study for all children between 3 to 5 years of age. The treatment will be first removal of tonsils and adenoids if indicated, weight loss if there is obesity, positive airway pressure, and other surgical considerations rarely. Practical concerns is accessing sleep study monitoring, having people who can actually do the study and technically interpret it. Difficulty in performing the test because you need to do overnight studies and have things put in, like electrodes put in, which is not very easy for the children. But with over time and experience, you do get better, and use of CPAP. Our research agenda at this point in time is we don't have very good reliable monitoring tools, or the monitoring tools are very difficult to assess. Is there a role for sleep position rather doing any surgical interventions? Do you need to start desensitizing people to CPAP because it's very difficult to put on CPAP in children? What are the long-term efficacy studies? Whether you put CPAP early, are you better off at the end of it? What about obesity? Can we attack that as the simplest form? And what is the role of passive smoking? And these are things that people have to take up over time. And thank you very much for the attention.
Thank you, Dr. Bhavani. That was a very articulate and very precise talk. You covered 3 or 4 of the more important worries of most parents. Thyroid screening, I think you have told us very clearly, is mandatory. There are different age groups. For the first year, it's every 3 months. After that, it's every 6 months. So one normal value doesn't mean you may not get an abnormal value. So the take-home message from her is that you need to keep at it and do it periodically. And even if there is a subclinical hypothyroidism, it is important to treat. And growth charts are different for Down syndrome children versus normal children. So don't think your child is lagging behind, other than whether they are going to standard deviations less within a short duration of period. And the cervical instability, I think a lot of us tend to miss out. So it's very important. I hope you've understood that if you're going to put your child in some specific sports, that it's important to screen them, to pick it up early, and do appropriate therapy. And obstructive sleep apnea may be causing a lot of discomfort, hypoxia, so it needs to be addressed. Thank you, Dr. Bhavani. That was a brilliant presentation. Any questions? Dr. Bhavani? Yeah.
Sorry,
You've generated more controversies now.
I did, that's right. Yes. At present, that's from USA. I don't think we have very good, robust studies from other countries, not that I've seen. Okay. Now, I think world over, we are kind of, from what I can see, is about the same, unless, sorry. I think the survival figures have actually reached that kind of numbers in countries that pick up congenital heart disease and treat them early. I think that's really made a shift. Over and above, the nutritional and also the general well-being has definitely improved. But I think congenital heart disease has definitely made a difference. And I think if we have to do local studies, we have to actually do the prevalence all the way from young age and to see how we actually fare at that point in time. So I think we don't have very good, I can't see very much in Asia Pacific at this point in time. Oh, yes.
I need your email ID because we are running short of time and this topic needs to be addressed a full day required for this topic.
Sounds excellent, yes. Absolutely, will do. I'll just pass it on to, or I'll meet you at the end and pass it to you. Not a problem. Yes.
I really enjoy your talk. Hello, I'm here in the middle.
Here, yes.
Right. Yes, you mentioned about the autoimmune thyroiditis.
Yes.
Yeah. What are other inflammatory conditions? Do you see these children are more prone to inflammation than general, same age group? in normal children?
Yeah, I think there have been a lot of studies which have looked at the immune status, they've looked at subsets of antibodies like IgG, IgM, and there have been a lot of publications to address that issue on susceptibility to infections and also that your prolonged infections tend to happen. And that is, yes, it is true. There are published studies.
Okay, thank you.
Last question.
Lie on that person, and then she prefers to sleep. Her sleep duration is fine, it's almost 9 hours, and all the symptoms you were told, like headache or any behavior changes, that is not there. But she wakes up in between, sits for a while, and prefers to sleep on a raised position. It can be sleep apnea.
Sir, I was just going to tell you, if you just did a survey here, you probably will get 100% for that. So when I started practicing and looking at sleep-related disorders, I thought it was as simple as this. Just ask this question with parents and say, how does your child sleep at night? Are they restless? And then I suddenly found that everybody was saying the same thing. That never sleeps on the bed, goes on the floor, lies on the prone position, very restless, gets up at night. So sleep postures itself, if you take, it's a separate study, and there have been multiple studies which have looked at just sleep postures in children. And I think nearly 60-70% of them present with all that you said. And that's why it's become important. Remember, I was talking to you about hypothyroidism and identifying Down syndrome, hypothyroidism. It's almost the same. Very difficult to identify just based on sleep patterns, and very difficult to say, if you have a bit of learning difficulty and sleep pattern, are you qualifying into a sleep apnea kind of syndrome or not? So, which is why it's become like a screening tool now between 3 and 5 years to suggest getting a sleep study. But I do understand the difficulties of getting sleep study. It's not so easy. People are trying to work at alternative methods, whether you can do oxygen monitoring at home. There are lots of ways in which you can detect sleep-related disorders in adults, but we haven't extrapolated it to children, and especially children with Down syndrome. So I think that's work being done now. But if you do have what you were mentioning as concerns, I would certainly suggest you at least discuss with your physician on how you're going to follow up on this pattern.
Shall we get any test done or sleep pattern test done?
How old is your child? I'm sorry?
She's about to turn 6.
About to turn. I would.
Okay.
Excuse me, ma'am. Are there any studies to show the age of onset of dementia, Alzheimer, or cerebral atrophy in Down syndrome? Because I happen to know one patient. I'm Dr. Mukesh Verma from District Civil Hospital, Jalandhar. He developed cerebral atrophy at an age of 40.
I think it's a well-known correlation. I am going to actually I think there are good speakers who are going to talk about dementia and aging tomorrow. You should listen to the experts. But it is true. It is true there is a subset of persons with, or adults with Down syndrome do have features of dementia and Alzheimer's, or what we call Alzheimer's disease, dementia. But I think it's very, very